11:04, Dr. Payne Show, ready to roll. 416-870-6400, star 640 on cell. Bring it on. How you feeling, pal?
Feeling good.
Yeah?
Yeah. My wife's, we're expecting our first child, so she's overdue.
Jeez. So, how's the stress level?
Anxious.
Yeah, you're good.
No, stress is okay. It's just it's getting to the point where we're anxious, right? We want to meet this little baby and whatnot. But
you think you do? How about your wife?
Yeah,
Wrap
I know.
it up.
Yeah, no, for sure. Why is it always more about the wife and not? Why do I
don't
not
know. She's
matter?
had a second human inside her for 9 months, maybe.
True.
Yeah,
but I've been taking care of both of those humans.
That's true. You wait.
Yeah, exactly.
You wait.
I know.
You
I
wait,
know.
Son.
This is the easy part for me.
You have no gray hair yet.
Yeah, I do.
You still look young.
I got some, but it definitely going to change.
What else is going on?
So I really want to start the show by talking about our new clinic out in Brampton.
Yep, beautiful.
I think it's important. It's a great model of care for people, especially living in that area. So it's on Mississauga Road, just north of Steeles. The actual street is called Montpelier. It's walk-in clinic, family practice specialist, the rehab center, of course, pharmacy, lab, all. A one-stop shop. So if you're living out in that area, the Brampton West area, Georgetown, Milton, and are looking for a great place to have all of your healthcare needs taken care of, definitely give me a call, because the family doctors are accepting new patients, and those things fill up quickly, right? We all know it's a large space. It's about 11,000 square feet, so it's a facility designed to essentially accommodate all of your needs when it comes to healthcare. Right. And not to mention that the people that are there are exceptional people. All of the healthcare practitioners are incredible and good, hardworking people that genuinely care, and that's an important thing. But it's a great model because, and this is a lot of the models that I've created. I really tried to have that multidisciplinary approach, right. And I think it's very important that you find these types of centers where you can get all of those needs in one place. And the important part about that is the communication between the professionals. And a lot of the times, the lack of communication between professionals is really what prevents a patient's prognosis or their likelihood that they're going to get better. And so it's very nice when, and I'm not the only one doing these models. These models exist in a lot of places, but that multifaceted approach is extremely important for when you're looking for your good appropriate healthcare needs. And so, again, if you're out in that Brampton West location, Milton, Georgetown area, and you're looking for a place for all your healthcare needs, you have to give me a call. I'll point you in the right direction for the right people, depending on what you need. And I think you'll be very happy.
Good. You're just getting started, really. You're going to do this again. I know you will. As far as this type of care
No,
it's needed. That's why.
Yeah, it's definitely needed. We have a large network already, but this is something new, and we definitely wanted to talk about it today to promote it, essentially, right? Mm-hmm. It's brand new. Typically, I've taken over clinics that are existing.
Right.
I very rarely have done. Actually, I've never done a clinic from scratch. So it's been an interesting journey, but the nice thing about starting from scratch is you really create it the way that you want. The issue that I found with taking over clinics that have existed, although it's great because there's already a patient base and you can go in, but people get stuck in their bad habits, and not on the patient side of things, but on the procedural side of things. And I really want to put my vision into something and see it work a certain way. And so when you're taking over something, you're often also taking over the good and the bad, or not the bad, but the things that are maybe not as ideal as I would like them to be. And I may be wrong, right? I'm not saying my point of view is more right. It's just whoever was the previous owner was seeing it a certain way. But this is the model that I'm trying to build, the multidisciplinary, multifaceted approach to all different types of healthcare needs, because the research is there to support that that's what works. And so it's been an interesting journey, and I'm very excited, and I think it'll be great for that community.
Anything interesting walk through the door this week you want to talk about?
This week I actually had off for my wife because this is when she was expected. However, I have had a lot of emails, and I actually just received one, and the person mentioned it was confidential, so I won't go into too much detail because I don't want to breach this person's privacy. But essentially, this person was saying that she came across me on the internet. She's never heard the show, and she listened to the show, and she's been listening on the Global News website where the podcasts are. And she really said that she really enjoyed my approach to healthcare, and the things that I said resonated with her. And this isn't something new. This is what I hear when people come in to see me. It's just simply because whatever I'm saying is resonating with what they're thinking, and it's making sense to them. And that's always what I've said should be your indicator to whether you're seeing the right professional or not. So if you're seeing somebody and you're not having that feeling that, yeah, everything that this person is saying is making sense, right, and it's sort of I agree with, if you don't have that type of feeling, you're probably in the wrong place. And even worse, if you feel like there's red flags, because there's a lot of healthcare practitioners out there, doing the wrong things, then definitely get out of there. But if you've heard what I've had to say over the years, especially here on this platform on Global News, and it really hits home with the way you're thinking, or it makes sense, then you need to come see me. And I get all kinds of people that say, I've been listening for a long time, and I've been meaning to come there for my ankle, my knee, whatever it may be, yep, and I'm finally getting around to it. The one thing I still want to get across, and it's probably the most important message that I have on this show, is that you need to intervene early. When you wait a long time, that's when it becomes more difficult. And so, yeah, exactly. You're a perfect example. But you need to intervene as soon as possible. You need to be doing the right things as soon as possible. And the only reason why that is for you. If you do that, you are more likely to potentially get rid of the issue, maybe not completely, but very much, or at least have it in a very manageable state. Mm-hmm. It is always harder. It doesn't mean it's impossible to help manage someone else's issues, but definitely much harder when you have people that have the chronic issues. Right. And we're here to help those things as well. But I think with this platform that I have here, what's important, if you're listening, if you feel things and it's early, don't say, it'll go away, I'm going to leave it. No, this is when you intervene. It's very, very important.
We'll take a short break in that regard. Bring it on, your phone calls. You have pain questions, health questions. That's why we're here till 12 o'clock. 416-870-6400, star 640 on cell. It's a Dr. Payne Show. Global News Radio, 640 Toronto. 11:15, lots of time. Open lines, 416-870-6400, star 640 on your cell. Bring it on. You have pain questions at all. That's why we do this hour each and every Saturday. Car accidents.
Yes. Oh. Yeah, and I wanted to talk about that this week, especially with the weather, and it's unfortunate, but it is the time of year where these things are, car accidents happen all times of the year, but definitely more prevalent. If you've been hurt in a car accident, you need to start therapy. Believe me when I tell you, we also run a medical assessment business where we essentially see people who are hurt in car accidents after a long period of time to conduct what are called independent medical evaluations. Yep. And we do it both on the plaintiff and defense side of things, so we see both sides. But the point of why I raise that is not for the legal side of things, but I see how many people develop chronicity out of their car accident, okay, and I also see how many people go get treatment, and it's the wrong type of treatment. There's very much a protocol that should be followed with the simple strain sprains. Obviously, when you're dealing with fractures, things like that, the serious stuff, we deal with all things, but definitely the vast majority of car accidents are the simple sprains and the soft tissue injuries, and people think those are just things that will go away, or they go to clinics where they're just slapping machines on them and not making them do the exercise component. Believe me, you will regret that. And I am telling you that firsthand because of what I've seen in clinical practice, what I've seen in my businesses when we deal with these IMEs. If you are not following the appropriate protocol after a car accident, it's a very sad state of affairs in the long term, because even a small fender bender, when you consider, like if you said, I was rear-ended at, 40 kilometers an hour.
That's a
lot of force. That is a lot of force. Like sometimes people, like in MMA sports, get hit in the head, and that can cause problems for the rest of their lives. Imagine a car at 40 kilometers an hour at 1,200 pounds, 1,300 pounds, depending on the car, hitting you. You think that that's not a significant impact on your body? You're crazy if you think that. Trust me, even if you think you feel fine, go do the right exercises, go do the right rehab program. You will be very happy that you took my advice on this.
416-870-6400, star 640 on your cell. John, good morning.
Hi.
How are you?
Not bad.
Okay, what's up?
Better safe than sorry. I want to ask, I'm diabetic. I am not blind, but I have diabetic retinopathy.
Yep.
It's not clear skies. There's fog in my eyes. It's irritating.
Okay.
Can anything be done?
Well, have you seen an optometrist or an ophthalmologist about this?
I have. Unfortunately, I'm only 62. If I was 65, OHIP would be covering. I'm not. I have to dish out $3,000 a month, $1,500 per eye to get one injection.
Mm-hmm.
Deep down, I don't think it works.
Well,
other methods, natural path, controlled voltage, or stem cells. Like I've been doing research on the computer and so on. I want to know if you people know anything.
what do you mean, you people? Like, do I know anything about this? I'm not an optometrist or an ophthalmologist, so no, I don't specialize in these things.
Okay.
But what I can tell you is that you need to be seeing that type of professional for this type of issue. And also when you say these other things like potentially stem cells.
Controlled voltage.
So just let me finish my thought, please.
Okay.
So when you say those other things, there's going to be a cost to those things as well.
Yep.
Okay.
And those are not things that are free. And I mean, I get it. People, like, when it comes to healthcare, though, I don't think you can be putting a price on these things.
Okay.
And I think it's very important that, you know, I'm sure if you ask people that have let things go the wrong way because of money, they'll tell you that if they can go back, they'd find a way to get the money somehow in order to pay for these types of procedures. And my recommendation would be that if you have that diabetic retinopathy, that the most ideal people to be seeing are an optometrist or an ophthalmologist. And I'm not sure what the pricing is of those things because that's not the world I deal in when it comes to healthcare. But there are the people that are the experts that would know the very best. And even if there was something else that they could do, a naturopathic treatment, a stem cell treatment, I'm sure that they would recommend it. But remember, as practitioners, our job is to make evidence-based informed decisions for the patient and to recommend the things that have the most clinical scientific evidence. And a lot of these things, stem cells and whatnot, they don't have that research, and that's why they're not readily available, and that's why they're not done all the time. It may very well work. We don't know that yet, but it's not something we could jump to. So I think your best bet is to listen to the professionals on this. And do the treatment that's required before that retinopathy potentially leads to something like blindness, because that's unfortunately... Now, let me ask you another question. Is your blood sugar controlled?
We lost him.
Okay.
Disconnected. So if it's getting the diabetes in check too, right?
Well, potentially. Now, at a certain point, the retinopathy. So, diabetic retinopathy is a similar thing to the neuropathy that we've talked about, where high levels of blood sugar are overall corrosive to the body. That's why these things happen. That's why people with diabetes that are uncontrolled develop retinopathies, neuropathies, which retinopathy just means pathology of the retina, which is a component of your eye. Neuropathy means pathology of the nerves. But the underlying cause is the blood sugar. So also, obviously, keeping it's incredible how many people I've met that are diabetic in practice. And do you have your diabetes controlled? And they say yes, but then you ask them about their diet and they're eating all the wrong things. Yeah. It's like they just rely on the medicine. You need to do the right things as well.
Get that keto happening. Well, there's an angle. 416-870-6400, star 640 on cell. Lots of time, lots of room for you to call in as well. Sharon, we'll get to you after a break, and you as well, hopefully, here on the Dr. Payne Show. Global News Radio, 640 Toronto. 416-870-6400, star 640 on cell. Sharon, thank you for hanging on. How are you?
Hi. I may be a bit nervous.
That's no worries.
It's okay.
It's okay. Just talking to us.
I've listened to you every chance I get.
Great.
Thank you. That's very nice.
And I realize you really give good advice.
Thank you.
I had a surgery, and I had an injury in June 2017.
Okay, of this past year, sorry?
Yeah.
Okay, yeah.
And I've been feeling pain ever since. I decided to have this surgery on September 14, 2018.
So Sharon, sorry, what was this for? What did you hurt?
For my shoulder.
Okay, and then you had surgery in June for this. Do you know what the exact injury was to the shoulder?
It's it's a tear.
A tear in the rotator cuff, okay.
Yeah.
And then you had the surgery, and you're still feeling... Did you have pain prior to the surgery?
I had pain prior. I hold on having the surgery because my doctor told me it wasn't guaranteed. Right. But when I realized I still couldn't do the stuff I normally do at work or at home, then I said, this is it. I'm going to have the surgery. I'm going to try it.
Now, let me ask you something. Prior to the surgery, did you have a problem with the motion in your arm? Like, was your range of motion limited?
Yeah. I couldn't put my arm up.
And what about now?
I can put it up with pain.
Yeah. So
but when he did the surgery, there was frozen.
Right. So that's a very, very important thing that I don't think is communicated enough when it comes to surgery. Surgery is very good for the improvement of function, and that's the right reason to be doing surgery. It is the wrong approach when it comes to just pain. So if you ask me, if you prior to this surgery had limited function and pain, and now you have better function but still have pain, that to me is still considered successful because it's mainly for the function that is most important. It's often not a good approach for pain management because pain could be caused due to a lot of other things. Now, I have two other questions for you. One, did you do any type of therapy prior to the surgery? And second question, did you do any therapy after the surgery?
Yes, I did before the surgery. I've been going physio.
Good, okay.
And after the surgery, I continue going physio, which I am right now.
Okay, and what are they doing with you at physio?
So I'm working with occupational therapy and also the physiotherapy.
Mm-hmm.
I felt like I saw like 30% better.
Okay.
I say 30% because I feel the pain every night still. I feel pins and needles. I feel burning.
Right.
So when I do anything, like any movements, like when I try to, dress or anything, mm-hmm. I feel the pain still.
Okay. So I think it sounds like you did a lot of the right things. Like I was saying, though, a lot of the time surgery is not the right protocol for the elimination of pain. But I think what you should do is come see me for an assessment and let's take a look at the shoulder closely and figure out, because a lot of the times when it comes to pain, the pain that you feel in an area may not necessarily be due to the injury specifically that occurred, but could also be due to other muscles and structures that need to compensate. So I think you need to come in. We can take a look at it, and from there we can determine what the best approach going forward is to help you with the pain.
Because I'm seeing the specialist that did the surgery,
mm-hmm.
like he's very good.
Yep.
Like I am seeing him right now, but I'm just wondering. I'm just wanting to know: is it normal for me to feel this type of pain, like pins and needles constantly, and feel pain every day after the surgery?
It's a hard question to answer. Is it normal to feel pain? Yes. Is it normal to feel pain? No. Right? Right. Yes and no, because pain is a very important aspect of us being human. It gives us an information to withdraw and to take care of ourselves. Is it normal to feel prolonged pain when the injury should be healed? No, and that's why there's a whole branch of medicine related to pain management. So it's a hard way for me to answer it. I'd have to see you in order to determine what exactly is causing your pain, because I'm not sure, based on this conversation, what the pain generating source of your shoulder is.
Okay, Sharon?
Okay.
Okay, I'm going to leave you a number to call as well. 1-855-55 Lou, DRLOU. 1-855-55 Dr. Lou, DRLOU. Make that phone call. Get a hold of the good doc here. And move on from there. Still plenty of time for you. The lines are open and ready. 416-870-6400, star 640 on cell. Dr. Payne Show right till 12 o'clock. Global News Radio 640 Toronto. 1132 and 416-870-6400, star 640 on cell. You have questions about pain, about a physical issue. That's why we're here every weekend. Bring them on. Lines are open. Can you just cut off my arm, please?
Where do you want it amputated?
Shoulder or neck.
But we just said
or
that.
From the neck down.
We just said that surgery is not necessary.
This is removal. This isn't surgery.
Well, removal is a type of surgery.
Yeah.
No, but that's
Good
an important
times.
point with Sharon that we brought up there, that surgery should very much be something that you opt for, and most surgeons will recommend it mainly for function. Okay. But if it's just simply pain, now in her scenario, she had both. And I think it's also the point that this needs to be communicated to people, that this will be very good for the function of your shoulder. So if you've got limited abduction or flexion, whatever range it is, with the surgery, we can likely improve that. But pain is so subjective. It's really hard to say what happens to people following that. It's even something like a knee replacement. Now, a lot of the times around osteoarthritis of the knee, a lot of the pain is due to the swelling within the knee.
Okay.
But a lot of the times, the reason for surgery is also function. They can't walk anymore. They can't move. A lot of people following a knee replacement might very well say, well, I can definitely walk, but I still have pain. Well, again, it is not the best solution for pain. It's not even close to the best solution. But it's definitely a good solution if there's a problem with function that can't be changed with just manual medicine and physical therapy. Then you need to use surgery. But it's very important that people who are considering surgery make sure that they understand that point, that this may very well help, again, with the function of the problem that you have, but it may not necessarily help your pain. But it may not.
They're mutually exclusive, basically. There's no guarantee that you're going to get both for the one, right?
No. And again, I guess it also depends on what's creating the pain, right? So if you give the example that you've got, an osteophyte on a nerve and that's causing burning pain down your arm, for example, well then, yeah, moving the outcome of that surgery is to remove the osteophyte to eliminate that nerve pressure.
Right.
But that doesn't mean you may not feel some generalized soreness still and other things that revolve around that. Once your body goes into pain, it responds in so many different ways. And then we move on to, as an issue becomes chronic, the component of learned pain.
Yep.
Although it may not be there, physically, you can still feel pain. And again, the example that I always go back to is the phantom limb issue, where people who have lost a limb for whatever reason can still feel something happening in that limb. And that very much shows us that that pain is not just something that happens in the body. In fact, it doesn't happen in the body at all. It happens in your brain. There's a message. All that we sense in our bodies is what's called nociception, or an uncomfortable stimuli. That needs to be taken back to the brain, and that information needs to be processed, and that will give us a response. It's the very reason why with spinal cord victims, you could light their foot on fire, for example, and they wouldn't know. Right. Because you wouldn't be able to feel anything, because there's the area that communicates in the spinal cord is severed, and so that tells us that pain is not something you feel in your body; it's an experience that happens in your brain. And that's an important component to understand around pain management, because once you can appreciate that component, if you're living with any type of chronic pain issue, and you can understand this basic concept that pain is created in the mind and not in the body, you'll start to understand why people will tell you, but there's no physical problem left. And a lot of the times the definition of chronic pain in certain patients is the absence of a physical problem. So the physical issue is gone. They may have had a physical issue, but it's then gone, and there's still a response, a pain response. Okay. And that has to do with pain being learned. It's still a neural pathway. The same thing, the same way we've learned to do everything else through our lives. You've learned to walk, to eat, to breathe. Well, not to breathe, but to breathe and eat at the same time. You learn all of these things. You don't think about it anymore. Pain becomes the same way. You can just have that learned component, which is why part of that multifaceted approach to pain management also includes the psychosocial treatments, the cognitive behavior therapies. And that doesn't mean you'll eliminate it, but it's also one big component of cognitive behavior therapy is also acceptance. And a lot of people that are living with their chronic pain issues haven't accepted that this is just what they have. Right. And I think once you can accept it, it provides a certain amount of relief to understand, okay, this is it. Stop feeling sorry for yourself. You have chronic pain. Accept it and move forward. Let's manage it so that you can live your lives.
Do you think that's, the gap between surgery and relief of pain, is that a large reason why there's been a drastic reduction in back surgeries?
Yes. Yeah, absolutely. So once upon a time, back surgeries were done for pain,
right?
More so, and we've seen the outcome of what's happened after all of those surgeries. So, definitely spine-related surgery is very much reserved when there's a serious problem with function. So you can have a very bad disc herniation, but unless it's causing you a functional problem or you can't move or anything like that, no one's going to intervene. But a lot of people have disc herniations that provide, some, subjective numbness and tingling, very hard to objectify on proper neurological tests. And so surgery is not the right answer. And I mean, spine surgery is no
kidding.
Simple matter. Like that's as difficult as it gets. And so you definitely want to be intervening when it's most necessary. And there's been a lot of failed back surgeries over the years. And that's why it's less and less prevalent, because we know it works. It works for the people who it's meant for. It will work very well if you need it. But there's a lot of people who just want to have spine surgery because they have a little bit of pain. That's not the reason why you do spine surgery. Absolutely not.
And it's funny because I know you've mentioned several times, even on MRIs or X-rays or other, that you've seen stuff where people have disc issues or facet joints. And it's like, this is not causing you any pain. Like, even you're surprised that this isn't causing pain. It looks like it would, but it doesn't. That just tells you right there.
We
right?
call them incidental findings. So we'll send people for some type of X-ray or imaging or whatnot, and you end up seeing something that you think like, wow, in someone else's case, this would really hurt. Yeah, like there's been people where I've seen severe degeneration in their spines and their knees, and it's not the root cause of their pain. Yeah, in their hips. And less likely, when you get to the extremities, though, especially hips and knees, severe osteoarthritis is often the cause of the pain. But in the spine, no, it's incredible. I've also seen people that have a tremendous amount of pain, and you send them for imaging, and everything's as perfect as you can imagine. Like it's textbook normal. And it's like, okay, well, what's going on here?
That sucks for a practitioner because they're looking for you for answers. They're desperate. And they want to know.
No, it doesn't suck, because if you're a good practitioner, you'll understand that a lot of the times when it comes to mechanical issues in the spine, it's simply due to deconditioning of muscles and tissues, and that they're just not working properly. And that's a good thing. If you have chronic issues, you want them to be mechanical, because that's the easiest thing to manage. You don't want these serious things because those are very hard to manage.
Or just in my case, you just told me to amputate from the neck down. So
you said it yourself.
We'll take a short break. 416-870-6400, star 640 on cell. You got questions about your pain, your physical issues, bring them on. You still got some time till 12 o'clock. Dr. Payne Show, right here, Global News Radio, 640 Toronto. And you want to reach out outside of the hour of the show, info@paincarecanada.com. And there's always 1-855-55-Dr. Lou, DRLOU. But back to this phone call. Gordon, how are you? Good morning.
Good morning, gentlemen.
What's going on?
Well, Dr. Lou, I've been medically diagnosed with degenerative disc disease. Consequently, I now have spinal stenosis in L4S1, L5S1.
Okay.
I was told by my GP that it is Aquinas syndrome. However, the orthopedic surgeon begged to differ. Irregardless of that fact, the orthopedic surgeon wanted to go in and do the spinal fusion right away, which I was hesitant due in large part to the failed back surgery syndrome. I am a 59-year-old man, overweight and out of shape. As I say, I'm hopeful to take baby steps towards that end should it become absolutely necessary for me to get to the spinal fusion. Now, question. One of the options was a laminectomy. The other was a discectomy. And during the interim, I will be going to Toronto. I live up here in the Midland Penetanguishene area. And I will be getting a lower lumbar epidural injection here within the next 2 weeks. Could you put in simple, like almost layman-like terms, if I could use that expression, the difference between a laminectomy and a discectomy, and how invasive are they?
Yeah. So what they are is so you'd have to understand the anatomy of the vertebrae, but the lamina are essentially the extensions of bone that enclose the spinal cord, I guess is the easiest way for me to try to describe it on the radio. A laminectomy is when where they will cut out that piece of bone to create space for the spinal cord. Whereas when they remove the disc, they're removing the disc, and the disc is a soft tissue structure in between the vertebrae. My assumption would be that in a scenario where you have spinal stenosis, they would probably opt out to open up the lamina versus the disc. Now, I'm also, we've also had on the show before Dr. Carlo Amendolia, who's an expert on spinal stenosis at Mount Sinai. I think there's more worthwhile options for you to try before surgery in terms of the rehabilitation approach for spinal stenosis. And that might be potentially I'd have to see you in order to be certain. I'd have to review how bad your stenosis is, but I would like to think that you should always opt out for more conservative measures before you go to the more invasive measures.
Okay, well, thank you for making that a little more simplified for me.
No problem.
And we certainly do have one great big pile of snow up here, and I can't even go outside and snow blow it all because my back's too damn sore.
That's right.
Yeah.
Thank you, gentlemen.
No problem.
Thank you, Gord. Appreciate that. Again, you want to reach out, please do. 1-855-55 Dr. Lou, DRLOU. Vish, good morning. How are you?
Good morning, guys. I'm doctor. I have 2 10-millimeter tear in each shoulder.
Okay.
I'm currently getting shots to control the pain. I think it's cortisone. I can't remember now.
Yep.
And it lasts. The shots last between 2 months to 3 months.
Okay.
And I have to go back to get another shot.
Besides these shots, what else are you doing, Vish?
I've been trying to stretch it out.
Are you doing formal therapy with anybody?
No, not as yet.
All right, you got to give me a call and you got to start some formal therapy, because just doing the shots is just so. It's funny with cortisone. So there are times where I suggest to people to have cortisone injections. I actually had a patient who had a similar type of injury to you, a shoulder issue. They're in so much pain that they can't move their shoulder.
Basically, it's getting to that point.
Yeah, my physiotherapy team, unfortunately, can't do very much with them because of how much pain they're in.
Wow.
So they got the cortisone injections. Why? Not just so that they can go home and hope that it goes away on its own, because it won't. They got a cortisone injection in order to be able to do the therapy.
So to get the pain level down to realistic.
Correct. So that at the very least, the physiotherapists can go in there, move it around, and it's bearable. It's not absolutely gone, but it's definitely within a point where they can do those things. So, I would think that is when you get a cortisone injection. You should be be trying to do the therapy at that time. But give me a call. I see you're in Brampton, which is great because we have our new clinic there, and we can set you up with the right people to help you out.
Definitely, Dr. Lou.
Okay.
I'll be calling. Thank you.
No problem.
Thanks, Vish. Appreciate that. Again, 1-855-55 Dr. Lou, DRLOU. Let's get Paulie in here before we break. Hey, Paul. Good morning.
Hi there. How are you?
Good, sir. What's going on?
I'm just wondering, when getting an assessment and such for back pain and neck headaches, all of that sort of thing, what's the difference between a chiropractor and an osteopath?
Good question.
Well, there's a lot of ways to distinguish the difference. Number one, from an educational standpoint, a chiropractor has to do an undergrad degree followed by another specialized degree in chiropractic college of another 4 years. There's a 1-year residency program, so they're essentially doctors as classified by the government of Ontario. An osteopath, and the other big thing here is chiropractors are a regulated profession, which means that there's a regulatory body that protects the public from the profession, and that's a big distinguishing factor in what a profession is. Osteopathy is in the States, a doctor of osteopathy is very much the same thing, but here an osteopath is very different. It's usually a 6-month program that can be done, I believe, straight out of high school. Part-time. The colleges are not regulated by a special education board like chiropractic colleges, and there's no regulatory body. It's still not regulated, which means there's not good protection for the public from the profession. So that's answer number one on the credential side of things. Answer number two on the side of the therapy interventions is a chiropractor, being a doctor, will be able to differentially diagnose, which means that you may present to a chiropractor with low back pain, but the source of the problem may not be something that they could treat within their scope of practice, and they're going to be much better able, based on the differential diagnosis, to identify that and make the appropriate recommendations, where an osteopath doesn't have that extensive training, and they're really working more on what are called mobilizations of joints, which is just putting motion through a joint. Now, we have osteopaths in the clinic that deal with patients, so it's not like I'm against osteopathy. I just think it very much matters that if you're going to see a standalone practitioner, that you understand those big differences in the quality of the professions, one versus the other.
All right, that's great. Thank you very much.
No problem.
Okay.
That was one hell of an answer.
Was it?
That was nice.
Yeah.
That was pretty slick, son. Not bad. Your phone calls, that's the type of detail you get here. 416-870-6400, star 640. On your still got some time to call in. Dr. Payne Show, Global News Radio, 640 Toronto.
The case.
Mm-hmm.
And then I also have pain in my upper right abdomen, which nobody knows why it's there. And so I'm just, and nobody can give me any answers. There's no pain meds that have worked at all. And I feel totally at the end of my rope here.
Yeah. So okay, I wouldn't say that, your first comment about that overall doctors have been useless. I would disagree with that because, number one, when a patient, how old are you, Rebecca?
22.
So you're young. So when a patient that's 22 years old has abdominal pain and bloody stools, they've done the right things to investigate the more serious causes of that pain. So that, although you think that's nothing, that they may have not given you a specific answer yet, they are ruling out very serious causes that if they found, you would need immediate medical attention. So it's good that they haven't found anything serious. That may very well mean that you still have an issue. Of course, you have an issue. It just may not be something that is, life-threatening or anything like that. So they're ruling out the most serious causes first, and that's good. And you said this started in December, is that right?
Yes.
Yeah. So it's overall relatively new. It does take time to diagnose these types of things properly, but the proper diagnostic process is rule out the most serious causes and move towards the benign causes of this type of issue. And when they're saying things like potentially IBS can absolutely cause those types of symptoms. And so that is more of a benign cause. Now, that doesn't mean, when I say benign, I just mean it's not life-threatening. It's obviously, bothers you and there's discomfort, but you need to assess those types of things. So, and if it does end up becoming IBS, then there's also a component of another big thing with gut issues is the amount of stress people have. And I can just hear based on your voice how stressed you are around all of this. And that's not going to help your symptoms either. And I'm not just saying just stop stressing out because it's not that easy. But you do have to consider that those types of issues are made worse, especially when there's a lot of anxiety around this type of issue. But I think the diagnostic process that you're going through is correct. You still haven't gotten to the bottom, but give me a call and I'll see if I can help guide you in a better direction or in a more appropriate direction.
Good for another morning. Thank you, Rebecca. 1-855-55 Lou, DRLOU to wrap it up. That's the number to call, and info@paincarecanada.com. Till next time, Dr. Payne Show, Global News Radio 640 Toronto.